PeoriaLife.com. This is the Peoria Life, and today we have a very special guest, Dr. G, aka Dr. Sarah Gebauer. Her title is a mouthful, so I'm going to let her say that part of it. What is it that you actually do?
I'm Sarah Gebauer. I'm a family physician and translational epidemiologist at St. Louis University School of Medicine in St. Louis, Missouri. I will note that my views don't represent those of my institution. They're my personal views. But what that means is, as I'm a family doctor, I provide primary care to patients in the safety net in St. Louis, Missouri, especially South County. And then I conduct epidemiologic studies to investigate a variety of health conditions. I'm particularly interested in how people's neighborhoods, where you live, impacts your health.
Yes, I want to know, I want to talk a little bit about how you got into being a physician and what that pathway looked like. Because I remember being in high school and there were some, I don't know what you would call them now, some issues that arose, and then it wound up kind of sparking this interest. Can you talk a little bit about what you went through and kind of how it guided you towards being a physician?
So full disclosure, Philly P is my younger brother, and so we grew up together in Northern Illinois. And what he's alluding to, and actually my interest in becoming a physician started before all of this. The first time I thought about becoming a doctor was actually when I was 12. And I thought about it and then dismissed it because I was scared of being responsible for another human's health and for making decisions that are that important to them. And then when I was about, it is, and that's important to have a proper respect for the work that you're doing and the lives that are in your hands and how important it is to establish trust between yourself and your patient. But then when I was about 15, I reconsidered it because I decided that I had done nothing important or of service in my life. I had this sort of, I don't know, existential crisis, if it's possible. Not even a quarter life crisis, like even less than that. And I decided in the moment, I was like, I'm going to be a doctor. And I remember I went and told actually mom and dad, and they were like, okay, cool. That's just really what happened, which is kind of goofy. But at any rate, then what you're alluding to is that, or actually right around when I was 12 or so, which I didn't really recognize was the case, I began having episodes that were later diagnosed as complex partial seizures.
Oh.
Which really
were
very, which for a lot of people where they saw them, I didn't know they were happening. And for what it started out as just this kind of feeling like I recognized everything that was going on around me. It would last for a minute or two and then go away. And what I called that was deja vu, because that's what it felt like. I recognized everything that was going on.
Oh.
And as time went on, those episodes got longer and longer until I felt like I was going to throw up, I could never figure out why I recognized everything that was going to happen. I couldn't tell you what was going to happen next. It wasn't like clairvoyance, but it was so confusing.
So there were,
go ahead.
So there were petite mal seizures?
So technically not petit mal. These were complex partial seizures, which actually have another different name now that is escaping me in this moment. But they start as a simple partial seizure, which is where one little part of your brain will fire. Now, classically, that can be, if that's in a motor part of your brain, that might be a limb that starts moving, right? But you remain conscious in a simple partial seizure. So because it's just in one part of your brain. Now, if you have complex partial seizures, again, I'm not using the right name because they've changed the nomenclature in the last few years, then that progresses just enough so that you lose conscious awareness of the world, but you're not having what people classically think of as a grand mal seizure. And so what would happen to me is that not long after this aura, because that's what I was experiencing, an aura, it would generalize just enough that I would lose consciousness. And essentially it would be like the lights are on, but nobody's home. So people could talk to me. I would be standing, I would be staring off. I might keep walking if I'm walking. I might keep doing whatever I'm doing. And then eventually sort of come back around. And people would be like, right, drum majoring. And we can tell that story if you'd like. But yes, and so then I would come back around and people would be like, what just happened? And I was like, I don't know, I just felt a little sick for a second because I didn't know I was losing consciousness. I had no idea. And so then the flashpoint was my senior night, football game, I was one of the drum majors of the band. So one of my jobs was to conduct. And it was the very last song. And I remember it was raining. I was stressed as heck because I was supposed to do this senior feature at the end, which was dueling maces because we spun mace in high school marching band. And I always had horrible performance anxiety. So I was really, really nervous because I hadn't had time to practice. And the other drum major was really good at all this stuff. And he was also a senior. And
well, Nathan, yeah, he's good at everything.
He was good at everything, right. And so as we were playing, and the song ironically was Time Warp, as we were playing the song, I was conducting with the drum line, and I remember getting the rising feeling, which is actually classic for the ultimate diagnosis. And then the next thing I remember, the song is over. Everybody's at the front of the field for the senior feature. I am in the back of the field facing the away bleachers, and I have no idea how I got there. And so I sort of ran to the front of the field and picked up my mace. And of course, this routine is totally blown. And I remember looking, because the song was supposed to be dueling banjos. That was supposed to be the idea. And I looked at the other drum major and was like, did we play that song? And he looked at me like I had 3 heads. And so I tried to get through the end of this routine. And it was raining hard enough that we didn't stay for the end of the game. We were losing. Everything was going, terrible. And we get inside, and my band director, who I really love dearly, she comes up to me and she starts yelling at me, like, "What were you doing? What happened?" And I'm just looking at her like, I have no idea what you're talking about. And I just remember the look on her face, because her face just fell. And it went from being angry to being scared. Because what had happened, what I found out later, so my best friend was the captain of the drum line. And she's like, here's what happened. You were walking and conducting, and then you stopped, your arms dropped to your side, and you just walked away. And one of my other friends played the sousaphone, and she was marching backwards. She almost tripped over me. And essentially, I spent the last part of this song just walking back and forth kind of aimlessly in the back of the field. Until I came to. And so, then my parents were there and saw this happen. And my dad called one of his friends who's a physician, was like, oh my gosh, this just happened to Sarah. And he said the same words that you put on it initially, petit mal seizures, which is a seizure that can sort of look like that. And, we saw our primary care doctor, they sent us to a neurologist, and I had an EEG, had all the stuff. It was all negative.
Well, I wanted to talk about that too, because I remember this being a real big sticking point as we were going through it. You're having these symptoms. If I recall, they had actually diagnosed you with epilepsy, and they were giving you epilepsy medication, and something was just off, and you had asked for a particular like an MRI or CAT scan. I don't recall exactly what it was, but you'd asked for some sort of imaging for them to go and look at it, and the physician said no, just flat out no.
Well, let me tell you what happened.
Please.
So we went to go see the neurologist, and we described the situation. I'd also had an episode that we hadn't really, I think, given enough credence to, maybe in the months or maybe year before this, where I had woken up and I had bitten up the entire inside of the mouth overnight. Yeah. And we just hadn't really recognized it for what it was. It was probably a secondary generalization of a seizure that happened, and to what people stereotypically think of as seizures. And so when we told him about that and told him about this, he's like, that sounds like complex partial seizures, which is a type of epilepsy, technically. And what he said to me is, okay, well, we'll start a medication. It's been going on probably for 4 or 5 years. If it was a tumor, it would have killed you already. So I'm not going to get an MRI because you can't afford it.
Yeah.
So, yeah. Right. And I had Medicaid at the time. So our family was going through some financial hardships. This was also pre-Affordable Care Act. So this was a very different sort of world in terms of what was allowed and how people approach people who have Medicaid. And so I remember he started me on a medication. It's called valproic acid. It's actually one today that we do not really ever start in reproductive age women because it can cause birth defects. So it's a very last resort. So the fact that he reached for this medication first was wildly out of step with how we care for this now and should have been recognized at that time. And I went back to see him, 6 weeks later, and told him I was still having seizures. And his response was, "No, you're not." He told me I wasn't, and that
I
that
was
wasn't
ready to
possible.
go down there and just grab this guy by the ear and be like, "What are you doing? Like, what is happening right now?"
I mean, I don't want to defend him, but in his defense, my EEG was negative. The test that we do to look for seizure was normal. What he had to go on was my history and what I was explaining, which were textbook complex partial seizures in the location that they ultimately were originating from, and that was determined. But he didn't believe me. And then about a month or so later, we received a letter at the house that I'd been dismissed from the practice and that I essentially no longer had a neurologist, was on a teratogenic medication that I couldn't afford. It was $60 a month. It was not covered by our Medicaid at the time. And so our parents were kind of paying through the nose for this medication that wasn't work. And so, it's February. I'm a senior in high school trying to figure out what I'm going to do with my life. And finally, the original friend that our dad called that night when I had that seizure in front of everybody, he actually ordered the MRI, and that MRI was done in March. The MRI came back positive for mass.
Oh, I didn't realize he was the one who ordered the MRI. I thought it was the guy from Rush Copley.
No, so he ordered the MRI, and I remember because then he called a few days afterwards and said, "Can I come over?" And as soon as he asked if he could come over, I was like, "They found something."
Oh,
That's the only reason that he would call like that, is because they found something. And I remember he came into our living room, he sat down across from me in one of the chairs, and he's like, and he's like, "Okay, we're gonna talk about the MRI." And I was like, "We found something." And he's like, "There's a lesion." And I was like, "What does that even mean? What does a lesion mean?" I know now that it's a very generic term for there's a thing on your MRI. But when you use that sort of terminology with, a 17-year-old girl, I was like, I don't like, is that a cut on my brain?
Something's
Like,
eating my brain.
what? I don't know what that is. And so, our parents were like, "Oh my gosh, they called our aunt, who's a pediatric nurse practitioner. And she said, "You know what? They asked for her help. What do we do now?" And so she then called up a pediatric neurosurgeon's office in the area. He's still practicing, Dr. Rugi. He's an Advocate Lutheran General. She called his office. He's the best in the area, and he doesn't normally take Illinois Medicaid, but I'm going to demand that you see my niece. And he did. He saw me and told me, and we went over the imaging results. The first thing I asked him was, "Why'd this happen?" And he's like, "Well, the first question you asked me is one I can't answer. I don't know how you got this tumor. It maybe has been here your whole life. It's probably not, cancer, because this has been going on for a while." And he was like, "Let's operate in 2 weeks." And I was just like, ain't nobody got time for that. I'm a senior. It's, March of my senior year. I have concerts, I have proms, I have graduations, I have stuff to do. I don't have time for this right now. And
yeah, because I think when you got scheduled for the surgery, I had a gig in Wisconsin that very same day. So like I was gone until like the day after the surgery. I don't even think I saw you in the hospital.
yeah, I went in for surgery 3 days after I graduated from high school. So I got to do all the things. And the way that I played it, because I told the surgeon I was going to wait, and he was like, "I'm fine with that. It's probably not cancer. If it was cancer, it would have killed you by now." In this case, that was a true statement as opposed to what the other physician told me. And he's like, "As long as you can sort of handle the mental pressure of knowing that you're going under the knife, in a couple months, then that's fine." And so I was just like, "Yeah, it'll be fine." And at that point, it was really just like, I'm at peace with whatever's going to happen. He told me there's a 75% chance that the tumor will be gone and my epilepsy will be cured, a 20% chance it'll stay the same, and a 5% chance it'll get worse.
How did that work out over time?
So I had the surgery, right? So I waited. I did the high school thing. I didn't tell like hardly anyone at school because I didn't want anybody looking at me and thinking that girl's sick and being like, "Are you okay?" I didn't want to be
The brain
reminded what was
damaged
going
one,
on,
yeah.
right? So I told almost no one. I told almost no one what was going on. So like my best friend, no, Maria, the band director, she knew, and maybe one other teacher, but no one else. And then I only started like sort of telling people like the day before I was graduating from high school.
Why did Misty hate me so much?
I don't think she did, but let's not get into that right now.
Sorry, she was
Maybe
she
it was
so
your
mean to me.
so much potential. So much potential.
Then why would she yell at me all the time? And I digress.
Anyway.
We can talk about that another
Talk
time.
about that another time.
We'll start a music podcast.
Yeah, it'd be great. But yeah, so then I went in for surgery on the 2nd, and I remember that day I was sitting next to my dad. I was 18 now. I'd only turned 18 less than a month before that. So it was one of the first things I ever signed myself for, was to sign my consent for treatment and my consent for surgery. And I showed them ID because I had to show them that before I got in. And I looked at the back of it and I hadn't signed it for organ donation. And so I was like, if I die, you need to donate my organs. I signed the back of my license and I handed it to my dad, who signed in the wrong spot. I think because he was scared, right? I think because he was scared. I mean, who wouldn't be? But at that point, it was very much, whatever will be. There's nothing I can do about this. I have to do this. I can't continue on with these debilitating seizures. And if I can be cured of them with surgery, then of course. And we need to know what this is that's growing in my head. And I mean, I ended up only being in the hospital Wednesday. I went home Saturday morning after that. Really just a minimal incision just at the side of my head.
Yeah.
And I
remember the staples or whatever you had in there, and it was shaved a little bit.
And we went to like a family party right around the 12th, and my cousin, who actually we went to go to her wedding just this last fall.
I know, I missed it.
It was lovely. It was beautiful. But she came up to me, and she was, substantially younger then, and she's like, "Can I see your blood?" She's I think in the medical field now.
I know her mom was a nurse for a long time.
Well, I know she worked for a Dial, if you remember, for a while there when we were kids.
A what?
Dial, the soap company.
Oh, really?
Yeah.
No, I mean, I knew she was doing some nurse work at some point.
I feel bad. Sorry, Aunt Lori, if you listen to this and we're
I could be wrong. Well,
talking about it correctly, but yes. So I had the very last seizure ever that I've had on that day, on June 12th of 2004. And since that time, about a year later, I was weaned off of the seizure medication. And ultimately, it turned out, get ready for this, that I had a dysembryoplastic neuroepithelial tumor, or DNET, which is a
benign tumor.
It is benign.
Deep in your temporal lobe.
That's correct.
That's all I remembered.
Yes, that's correct. So it was behind my eye, about so big.
Was that big?
It was a good size. And they used intraoperative MRIs. So they took me in for surgery. They opened me up the first time, took as much as they could, kind of, as far as I understand, and I could be getting this wrong because I was asleep. I was there, but not there. They kind of patch you up. They put you in the MRI machine. They see if they got it all. And if in this case they so they pulled me back out, continued to do some more, stuck me back in the MRI. I believe we're like, oh, not quite again, and had to bring me back out and finish. And then I remember the next day going for the post-operative MRI, which was clean. So now if you look at my MRIs, I have essentially a CSF, a cerebrospinal fluid filled like kind of cavity inside my brain. And likely I read about it a lot after, once I was in medical school. And that it's a relatively rare tumor. It's not a very common tumor. It's benign, probably was there most of my life. And because of its location, which is right near the hippocampus, which is part of where you form your memories, that was likely why I was getting that sensation of deja vu, because it's so proximal to those areas where you form memories and understand that you remember things. And so that's why I would get that sensation, which is absolutely classic for the location that the tumor was in and where the seizures were originating from.
So I don't want to hijack this whole thing. Melissa, do you have any questions for Dr. G, or want to follow up on anything she's talked about so far?
It's a really interesting story, and the way you handled that, I can't imagine myself being so calm about it. I got very upset though when you said, I'm not defending this doctor, but I'm going to defend him. There were so many things that I heard, and overall it's a positive story, but I was a little bit angry on your behalf.
Me too. Right.
And part of it is because I'm still in that Medicaid thing, and I get that feeling of, I hope there's nothing wrong with me because I know I'm entitled to the sixth best care available. But the fact that you were going in, and as a person of a certain economic level and as a woman, people saying, I don't believe you. Yep. And you saying, he did not believe me. And a lot of women experience that. And that's something I'd love to have a little bit of a discussion about.
Yeah, and I'm actually so glad that you brought that up, because that would be the place where I would say that I learned the most about being a physician, is that when you have been in that position where you're talking to what's supposed to be a highly trained professional, and you're explaining to them what you're experiencing, and they decline to do it, especially in this case. This was a completely indicated test that would have been paid for by Illinois Medicaid. Oh. It would have been paid for. He just didn't want to do it. And I can't, Monday morning quarterback what was going through his head, right?
I guess I would ask you, as a doctor now, you hear stories about this. How would you suggest a patient advocate for themselves, or if they're in that position, what should they say to their doctor or to their insurance to resolve it?
Yeah, and so to give you some extra context, so I provide primary care in a safety net setting. The patients that I mostly care for are Missouri Medicaid patients. And at this point, and I've chosen that at this point, one, because I had a service in my world. I'm a physician and I'm here to serve. I've been in the position that these patients are in, where I feel like I don't have good access to care. I need a physician that's going to listen to me, that's going to believe me, and that is going to do the very best they can to understand what's going on, to anticipate barriers like, I can't pay for my medicine. That's absolutely unacceptable, that a physician would prescribe a medication that their patient can't afford, and that wouldn't be sensitive to that or think about that at all. That's in my book wildly unacceptable. Oh, go ahead.
So one thing my dad actually does is, he's a retina surgeon. The thing is, he could make more money doing certain injections that aren't really necessary. He chooses not to do them.
Right.
Yeah,
right.
That's awesome.
And part of that is just the idea of evidence-based medicine. And that's something I teach at the medical school. And one of the first professors that our medical students see, although it's later in the semester now, is that I teach them, this is the science that underpins the decisions that we make when we're caring for patients. But this is also the science that underpins our understanding of the disparities and what people experience when they're, say, insured by Medicaid, or a wide variety, whether they're experiencing discrimination, women that are being discriminated against, especially, say, pain management. The same thing happens to people of color. They're discriminated against when it comes to pain management, and a wide variety of things, and even just a lack of understanding of the systemic racism that people experience throughout their lives, which is a lot of what has driven me into the research side of the field that I'm in, but also the work that I do at the medical school. I serve on the Diversity Council, I started doing that few months ago, because I'm helping, I serve on the climate and safety subcommittee. I'm helping to administer a survey coming up here in the School of Medicine to help us understand the climate. And I also mentor a lot of students doing research and things like that, and things like that. So I always tell people I have 3 jobs. One of them is being a physician, one of them is a researcher, and one of them is a teacher.
I have a question in terms of really policy.
Mm-hmm.
You know, as a physician, you know, serving people who, you know, may not typically be able to have access, where do you stand on something like a universal health care?
I personally believe that healthcare is a human right. Everyone should have access to high quality healthcare, to high quality evidence based healthcare, to physicians who care about them, and that's period, end of story. There's absolutely no excuse for any of it. No one should have to go into debt to get the care that they need. No one should have to shop around for the best price, because it's very hard to shop rationally when it's your body and your well-being. Like, how are you, like, who wants a discount hip replacement? That's not, that makes no sense.
Well, and what's crazy to me is like it's literally something that every single human that has ever existed is going to go through, and instead of putting in a system that's going to support the individuals going through it, how can we make some money at it?
Right. I don't believe, yes, I think it's unethical to be making profits off of people's health.
Not only that,
like that's
every single country that has published a single Medicare for all has not gone back on it. Basically,
yes,
they have. So, and also one thing that this is just my personal opinion, Medicare for all isn't enough. I believe that we need to still advance medical science, because there are still conditions such as heart disease, cancer, dementia that are still untreated. Not only that, let's be honest about something. We were not prepared. Humanity was not prepared for the impact of COVID.
Ooh, let's talk about COVID.
Like,
I'm just saying, Dr. G here is an epidemiologist. Sorry.
Because the fact that we're still recovering from the damage, there's some people still suffering from the effects of COVID itself. So I think what we need is investment into gene editing and cell therapy, because I believe for the next 20 years, the next innovation won't be in digital technology or computing or AI, but rather biotech.
I disagree. I think that the combination of genetics and artificial intelligence will be the thing that's going to allow us to move things into the future at a more rapid pace.
And I think we need to be careful putting all our eggs in the genetics basket, because then we are flirting with eugenics, which is a bad problem.
Yes,
I agree.
I totally agree.
Because let's be honest about something. When Marie Curie first researched radiation, could she have known that it would be weaponized? Her research, would be weaponized.
Well, so that I went on a long flight one time, and I met a student at Columbia University, and we were talking about medical devices and inventions, and we were talking, and she specifically was talking about how the use application, because typically when an inventor comes in, there's a problem that they want to solve, and they create the solution for that problem. Cool, now we've got this lovely solution. But the inverse of that is what can that thing be used for that could maybe do harm or bad? And having that thought and conversation is, should it exist? If this thing exists, is it going to be helpful, or will it in the long run be a detriment? And we were talking about that with the media.
Yeah, and the same arguments can be made for AI in terms of like how exactly we're using AI. And how it can introduce bias, for instance, and perpetuate disparities between groups when the data, because the AI is based on the data that you give it, and if you don't give it good data, then it's going to do it's just as biased as the people that made the algorithms. And that's
exactly why a lot of AI is just immediately racist.
Right. So you have to be very, very thoughtful about how you employ those things. Now, there are places where AI can potentially be helpful. So things like note writing, for instance, behind a clinician. So every time that I see a patient, I document everything I can about that visit. I boil down what we talked about into a series of what we call History of President List, or HPI. And that takes a little time and effort to make sure that I'm bringing in the appropriate things. And then I have to go in and document the history and make sure their medications are correct, document a physical exam for, the appointment that's appropriate for what's going on. And then I have to document my assessment and plan, which is what is it, how's it doing, and what am I going to do about it for each thing that I talk to somebody about. And so AI can sometimes help with note writing as it's following along the clinician. But there was actually a study that was published recently that was examining whether the AI was as good as the clinician or better than the clinician in making a diagnosis. And that I haven't been able to read that study to really, understand the nuances of how that works. But, a lot of when you're a clinician trying to make a diagnosis for a human, you have to gather all the right data, and then you have to synthesize that data into kind of the best possible fit for what could be going on. And many a times, it's not particularly clear. And especially in primary care, you have to be very comfortable with the fact that you may not know exactly what's going on. I can rule out the things that are dangerous or scary and that are reasonable to investigate. And that at the end of the day, sometimes someone's symptoms will go away and you'll never really know exactly what happened, because we don't really completely understand the human body. We understand a lot of things about the human body, and our knowledge has advanced exponentially over the last 100 years since we really have been able to implement the scientific process and the discoveries. But that also makes medicine extremely broad and very rapid moving, which is why we need to train physicians to be able to evaluate the evidence. Is it time to change my practice? Is the evidence strong enough that I should do something different, or should I stay the same? Am I taking a risk by changing the way that I'm approaching this, or should I stay? Should I stay or should I go is essentially what I have to train a medical student to do. It's what I have to train a resident to do. And then I myself have to then continually reevaluate the evidence, but I have to look things up a lot. I can't know everything about everyone all the time. In medicine,
thank you for acknowledging that, because some physicians, I know everything. Their egos get tied into it.
Well, and in my opinion, when people act like that sort of bravado is really usually I'm insecure inside, and the only way I can make sure that people feel like I know what I'm talking about is to talk in certainties all the time. And that typically when people are confident in their clinical skills, they are confident enough to say, I don't know, because that doesn't mean I'm a bad clinician if I don't know. If I have to go look something up, if I double check the dose of a medication, if I double check that this is the appropriate antibiotic for the infection that we're diagnosing today, if I'm double checking, this is the correct workup for this particular complaint, I'm making sure that I'm not missing something. And I flagrantly look things up with and in front of my patients all the time.
I love that. That was something I did when I was in sales too. Somebody asked me a question I don't know. It's like, I don't know, but I can find that for you.
Yeah, or I'm going to confirm it.
There were so many other people there that would just lie through their teeth, and I'm like, why do? Anyways, I want to talk about COVID, because going back to 2020, I just had my first son, Russell. He was just born, and 2 weeks after he was born, boom, like lockdown happens. And there's all this information coming out about the vaccinations, there were people that were sanitizing their groceries. Like, Ellie made me write down our groceries one time, and I was like, I'm never ever doing that again. I remembered calling you and being like, hey, I think I'm being dumb. Can you tell me just how dumb I'm being right now? Like, do I need to wipe down my groceries? But there was just so much misinformation out there. And what I really want to touch on was vaccines, because that was where I really got kind of caught up in the hysteria from mainstream media and everything else. Is this really dangerous? Like, am I doing something that's going to be dangerous for me? And then also on the inverse is that, like, I've got a newborn baby here. When is it safe for them to get vaccinated? If it's safe for them to get vaccinated? And this is coming from a place of, I've all the other vaccines, I've never had an issue with it before. So suddenly I've got these, seeds of doubt planted in my head around vaccinations and the mRNA delivery method. So could you talk a little bit about that? Because I remember when I called you and I was like, what do I do?
Yeah. So to be clear, this is a very broad sort of topic, because it all really starts with, this was a novel coronavirus. Like, we had seen other types of coronaviruses like this. COVID-19 stands for coronavirus. Let's see. uh, gosh, see, oh, sorry, I used to have this like in my brain right away. Disease 19. So there's the virus itself, that SARS-CoV-2, severe acute respiratory syndrome, coronavirus 2, because there was one already, and then COVID is coronavirus disease dash 19, the year that it was discovered.
That's what the 19 is for.
That's
I
what
thought
it's,
it was
yes.
like the 19th iteration, like a
No,
software
no.
version.
And I remember actually when I heard the name for the first time, it was February of 2020. I was riding in my car listening to the radio, and Mary Louise Kelly comes on NPR and says, the new virus has the virus has a name, the disease has a name, it's COVID-19. And it wasn't too far into March where, I was sitting in meetings. I work at a DPH clinic, at a public health clinic. And we were talking about what was going on. And it was probably the day after that meeting that we had the first case of COVID-19 in the St. Louis metro region. And then maybe it was a few weeks after that I was getting a text message from my colleague. I do take care of patients in the hospital, supervising residents in addition to my outpatient practice. And he pretty much texted me and be like, I'm putting together a team. I need docs that are willing to come in to volunteer to take care of these patients in the hospital. This is a COVID-19 only service. Are you willing to come? And I remember my initial reaction was fear, of course, because all that I could imagine in my mind was, what if I get this and then I'm picturing myself intubated in the ICU and my family saying goodbye to me? Because we didn't know anything. We didn't know anything about anything. We were preparing ventilators. They were telling us to use bandanas when we ran out of masks. Like, it's really terrifying when you're, being told to run into the fire, and being told, to wear a paper bag on your head and hope for the best.
Yeah, no kidding.
And I did my first round of inpatient COVID service in April of 2020. So this was only a month or so in. We had 50 some patients in this hospital, all with COVID-19, all various levels of severity. We had no idea, what we were doing. We were trying really hard. This was right around the time that we were pivoting from away from intubating early, more toward using supplemental oxygen. And I remember looking up papers on what to do, and anything that was older than like 2 or 3 weeks old was too old, because things were moving so rapidly, because we were trying to figure it out. And I did another round then in December of that year, which was a very different kind of world. By that point, we had good protocols in place. I felt pretty comfortable with our oxygenation and how we were approaching these patients. And I kept going back because I thought, I'm one of the youngest attendings we have here. If somebody is going to survive this, it's going to be me. If I were to get sick, I don't want these 70-some-year-old retirees coming in and dying on these wards, because there were people that were being called in that fashion. I was like, no, like, just send me. If I get it, I'll live through it.
You're a warrior.
Well, that's an overstatement, but I mean, we're taking care of these people because that's what we do. We're professionals, and our job is to care for people. We care for people with contagious diseases all the time. We wear now. By then, we actually had appropriate equipment. Like, we were re-wearing our N95s, and I still have like a weird thing about N95 masks that I just can't like throw them away after one use, because that's what we used to do. That's what you always do. Is you use it and then you throw it away. But we had to like put them in a paper bag, use them for multiple days. So we didn't have enough, and they would put them under UV lights to try to sanitize them and kill the virus at the time. That was what they were doing in April, and at the time they were offering it at the big academic medical center. But I was like, and I had to like raise this to the university. I was like, why aren't you doing it at this other center? You have faculty there too. You need to take care of us. But within the week, they were using UV lights at my institution too.
Oh, that's excellent.
But well, yeah, we had to pivot really hard. But so all of that to say that I remember when I got a call from that same colleague in December saying, we have doses of the vaccine. If you want one, come. And your first line, because you've been working on the wards, come. I no joke, drove 80 miles an hour to get a vaccine after what I had seen. After what I had seen, watching people die, watching just the fear and how scary it was on those wards, watching that happen, I immediately went. And then,
So my disappointment with the vaccine distribution is that why didn't they how do I describe, what's the right way to describe it? Basically negate the patent on the vaccines. Like, let me explain to everyone in the audience. When the polio vaccine was developed, it was developed by a man named Jonas Salk. The thing he did was that he deliberately did not patent the polio vaccine because he wanted it available to everybody. The vaccine he used particularly used a dead sample of the polio virus, so that way it would be safer and it would be able to be distributed. Not only that, anyone can make it and advise it at their own leisure. But the thing is, what Pfizer and Moderna and other companies have done is they deliberately patent it. Now, I'm going to sound like a massive conspiracy theorist. I believe that they are anticipating the coronavirus to get worse and mutate, so that way they can adjust the virus and sell it to a high price to wealthier countries while denying it to poorer countries. So because basically, to explain it to everyone, a virus multiplies, that gives it more chances of mutating, whether into a more infectious form or, how you say, a more deadly form.
I think it was just capitalism. I mean, if you're going to spend $100 million, or probably more than that, researching and building a vaccine that you ultimately want to sell because you're a for-profit company in America, like I would patent the heck out of it. I don't know that I would be anticipating another round, but I know what I essentially, once I have my technology to develop the COVID vaccines, then I would just be waiting for the next outbreak, but not necessarily from COVID, because like as climate change continues on the pathway that we are, correct me if I'm wrong, but we are likely to see a lot more epidemics similar to the COVID outbreak.
So let's take a whole big step back here, because we didn't get a chance to actually talk about the technology that's in the mRNA-based vaccines, right?
Yeah, so I'm curious the drawbacks and the benefits of mRNA versus previous use cases.
So the way that we actually talk about this when we teach this to medical students and at the medical school, and I did extensive reading myself on this through high quality sources to really understand, where did this vaccine come from? How is this technology developed? And the mRNA technology itself has been around for, at this point, probably about 15 years that they've actually been testing it. 10 years at the time that they were bringing about these vaccines. They've been administering mRNA-based technology to animals and in some cases humans for a decade by the time that they launched these vaccines. So if we were going to see some sort of severe detrimental effect, we would have seen it during that time. And historically, when vaccines are launched, almost invariably, if there's going to be a reaction to that vaccine, it occurs within 2 months of administration of the vaccine. 2 months. And that's based on all of the technology that's been used in the past, whether it's inactivated polio vaccines, for instance, or even live virus vaccines like we give, which is the measles, mumps, and rubella vaccine is a live virus vaccine. It's just a live attenuated virus. We've made the virus less strong so that it can be shown to the body without causing damage. It infects just a few cells. It can't infect a large number of cells, and it presents the virus in the exact same way that an infection would, but on a much smaller scale. And
Can I ask why we don't use that method for COVID? Wouldn't it be faster to develop and cheaper?
So that has to do with the way that these viruses work. So the example that I'll talk specifically about is varicella, which is chickenpox.
Yeah.
So that's a live virus vaccine that's been around since, if I remember correctly, the early 90s, but don't quote me on that.
I don't think we got vaccinated. We just got the pox. Yeah.
No,
so we get shingles later in life.
We're right on the.
I got the pox.
We are on the cusp of when the vaccine was launched. We were just old enough that we missed it. But the way that actual varicella gives you lifelong immunity after you've been infected is because you get something called viremia, which means that the virus circulates in your blood and your whole body just sees the heck out of this virus. Now, in the case of varicella, you noted it's called varicella zoster because zoster is shingles. So you never fully eliminate usually the virus from your body. It may end up sort of living in a nerve that then can reactivate and become zoster, which is shingles. And that happens classically when someone is immunosuppressed or older, typically. So a lot of times we'll remind your immune system that it's seen it before with a shingles vaccine, usually starting around age 50, or if someone's immunocompromised. But to get back to it, yeah, the way that vaccine then works is by trying to induce the same sort of situation with a virus that's much less likely to make you sick, and that will still give you that sort of high quality immunity. But the problem then on the other side is that that's not a typical upper respiratory virus that causes a respiratory illness. It enters your body through droplets, sure, but the way that it infects you is different than, say, a coronavirus, an influenza virus, or adenovirus that are going to come in through your nose, through your mouth, through your eyes. And so, so a respiratory virus, typically your body can get a respiratory virus over and over again. And that's because the type of immunity that is produced from that sort of infection is very temporary. It's usually, if I remember correctly, IgA mediated. And so your body it's not necessary most of the time to try and maintain immunity against a virus like that, because for the most part, that disease is going to be mild in most people, and your body can sort of forget it because of the way that it's entering your body. And so that's why you can get influenza again and again from year to year. The other part, though, is also that those viruses tend to be part of a phenomenon that's called either genetic shift or genetic drift. And that's where you get into why we'll focus on influenza because it's most well understood. Is that from year to year you'll hear, right? You've heard of probably H1N1, and those are named for the antigens on the outside of the virus. And so, or H5N2 or something like that. And so those, from year to year, there'll be a little of what we call drift. So think of it as being a little boat on the ocean, and it moves around just a little bit, not usually a ton. There is a lot of living memory immunity to that particular strain. Although people can still get sick, that will usually not become what we call a pandemic flu. Now, if you remember in then 2008, we had H1N1, which is the same combination of antigens as we call it the Spanish flu, but probably shouldn't. But the flu epidemic, because it's called Spanish flu, it's actually a spin thing that's marketing, trying to make the Spanish look bad.
I'm glad you brought that up. One of the things that I keep hearing in all these just in crap that I see, and I have no idea if it's true, but the theory that's going around is that the common cold that's out there right now is from the pandemic of 1918, and it's still something that gets passed around. That's just that's what I heard through people.
The pandemic of 1918 is H1N1, like that's influenza, like that's all it is. Like this is not groundbreaking to be thinking of that way. And that flu was
it's
pandemic.
The same thing though, right?
So kind of.
You know what this makes?
I gotta finish my explanation though, because you're getting ahead of yourself. Because what I'm getting to is the idea of shift. And that's where you see a strain that changes dramatically from one year to the next. You get H1N1 that hadn't been seen in living memory essentially since the pandemic, the flu pandemic in 1918. And now you have the potential to make a lot of people sick. And you typically in those pandemic flus, it's the people that don't usually get sick that are suddenly getting much sicker. And that's the young and the healthy. So in typical influenza, you're going to see the very young and the very elderly that are going to be impacted the most, and people who are immunocompromised, whose immune system don't work as well for whatever reason, whether it's a medical problem that they have or they take a medication that keeps their immune system in check if they have an autoimmune disorder. But in a pandemic flu, because it's a flu that hasn't been seen in living memory in large quantities, in this case since 1919, and then 2008, now you have a large swath of the population doesn't truly have immunity or much immunity from years and years of exposure. So now H1N1 has been circulating ever since then, and it's part of the flu vaccine ever since then. We usually vaccinate people against multiple strains of flu. I believe it's trivalent this year. So there's only 3 strains. And we usually try to predict the flu strains from the flu season that happens preceding in the southern hemisphere. Unfortunately, this year it's not a particularly good match, 30 to 40% effective. Most of what we're trying to do is keep you out of the hospital and keep you from dying. We can't necessarily stop you from getting influenza, but we can reduce your risk of ending up in the hospital or dying of influenza. If that makes sense.
Melissa, you had something that you wanted to add in.
Go ahead, and sorry about that.
No, that's okay. It was reminding me of sourdough or friendship bread, where you always have that same thing, but it's kind of growing and changing as the years go by. But you're always going to have that original bit of something.
The original sort of recipe that makes it influenza, right? But then there are the antigens on the outside that will distinguish from year to year that particular pathogen. And coronaviruses are the same way. They have their sort of drift and change because what they don't want to kill the host. That's actually bad. What they want is for someone to be pre-symptomatic and give it to as many people as possible so it can replicate as much as possible. Because killing your host is bad. Now I can't pass it on to anyone else. I need you to be minimally symptomatic or less symptomatic so that you can give it to as many people as possible so that I can replicate. I need to replicate the virus as much as possible.
Like a secondhand immunity? Is that what you're like? Catching a positive virus? Is that what you're saying, or am I?
No. So what the virus wants, if you can give it a want, is almost the same as really any sort of natural selection principle, which is that the more that you reproduce, the more you are selected for. And the way to be selected for is to replicate more. The more you replicate, the more copies of you are in that are circulating. And so the things that make it possible for you to replicate more are the things that are going to be the selected for virus. And so characteristics of a virus that's going to replicate more or be selected for are going to be viruses where people are not particularly symptomatic, that carry big viral loads, that have a pre-symptomatic period where they can spread the virus to other people don't realize they're sick. And so then you get sick from somebody, like you see them one day and the next day they're sick, you're like, oh crap, they probably maybe exposed me to the virus or whatever it is. And so that's why things get a little dicey when you see these viruses that are very dangerous and do have high fatality rates. So these are things like your hemorrhagic fevers, that have very high mortality rates. An example would be, say, Ebola or hantavirus. And those are spread in very different ways, but they're usually sitting in an animal population that then jumps to humans, and then that it can spread within that community.
I'm actually really glad you brought that up, because another thing that you continue to hear in the conspiracy theory realm of things is about the lab in Wuhan in China. Now, my understanding is that the particular lab that's being referenced wasn't engineering COVID to be out to like Lyme's disease, put it out and as a weapon, but they were scientists and physicians who were studying epidemiology and viruses in bat populations, because I guess the SARS virus is very common in the bat population, and they can kind of determine what may happen or what may come and transition over to humans from the bat population. Can you touch on that a little bit?
Yeah, so what I'll preface by saying is that I don't know that anybody really has it pinned down yet. And for a long time, they were very convinced that it was an animal market in Wuhan, that it jumped from the bats, and this is how it came to people. And some of the early folks that were trying to pin it on this virology lab in Wuhan were kind of shunted to the side. I think that they are continuing to investigate that because the government in China has been very opaque and has not been willing to share a lot of the data that would allow people to conclusively, truly be sure where the virus came from.
Regimes.
Now, from an engineering standpoint, if it was really trying to be a virus that would do the most possible damage and engineered that way, then theoretically it should have been significantly more deadly right from the outset, because it should have been perfectly engineered to kill as many people as possible right away. And that's some of what I've read a while ago, when I was kind of reading a little bit about what we understood about the origins and is this an engineered virus. So I don't know that anybody can actually for sure say where exactly it came from, because my understanding is that now even our government officials are starting to sort of to entertain again the possibilities that it did in fact escape that lab, or was it a zoonotic jump, or was it a combination of the two? I don't know that we have definitive answers, and like I said, part of that is because the information that we're getting from the Chinese government is very opaque.
I don't know. You play with bat poop, you get what you deserve.
You know,
JK LOL. Don't play with bat poop.
Not recommended.
Makes fine mascara. Literally though, guano.
let's sanitize at least first, right? About sanitary conditions. You're wearing mascara now. Right?
Oh, we had bats. We had bats at the house.
Yeah.
We had to call somebody to come out and get rid of it. It was a whole thing. And like the biggest scare is like, are we gonna get infected with some fungal disease or whatever?
Rabies is the thing you actually worry about. This is what you worry about. If you wake up in a room with a live bat, you need to be tested for rabies. You need the bat to be tested for rabies. You maybe even need to be vaccinated. You have to contact your local public health department, because that is a very real risk. And so even if, like I said, if you wake up in a room with a live bat, you presume that you have been bitten and you act like that bat has rabies until you know it doesn't.
Well, luckily, we just found a bat, and it was in the bathroom.
Yeah.
And the door was closed, and he was just laying on the floor. But it was like terrifying. It was like, what the hell do we do? Luckily, I had one of those like full body like hazmat suits. So I put on a mask, put on my suit. I'm like, all right,
call the public, call animal control. We got people whose job is to do that. So I would encourage you in the future to consider calling animal control.
Ain't nobody got time for that.
All I can do is encourage you.
I called the appropriate authorities afterward and I had to wait like 2 months. Turns out bats in the state of Illinois are protected and you cannot move them during their mating season, which is like July through September. So we had a bunch of baby bats getting born in our attic, and dude, we have this little like piece of like drywall that like covers up from like the attic and stuff, and there was like this little like corner that had gotten like just knocked off of it, and one day like a bat had like put its head down in the corner, so just its head was showing through, and it was just screaming, just making all of its bat noises. And Ellie's like, I think there's a bat somewhere in the house. I'm like, no, it's probably just our speakers, because we're watching like Batman or something with like squeaks and stuff in it. It's just the speakers. And then I walked up the stairs and I see this little bat head poking through. I'm like, oh no! Yeah, terrible day.
So on that note, did you want to continue talking about mRNA technology and COVID vaccines and kind of where we are now, or even how they work? Because there's all kinds of stuff that circulates about how they work. That's mis and disinformation.
I won't say who I went to, but I went to a pediatrician or a family doc. I don't know, something for my son. And we were talking about the vaccinations. And the question that he had was really for you, and it was, how is it worth it? When you have younger individuals, and there was, I can't remember the terminology that they used, but there was some reaction that individuals were having when they were having the.
You were talking about a rash. You were talking about a rash, a reticular rash, which is the fancy word for a net-like looking rash. It's a well-known side effect of actually COVID infection, and that people will get this reticuloid rash. It's benign and it resolves on its own. I mean, at this point, the CDC is really pushing most hard on older adults and people that are immunocompromised and people that could get very, very sick. I think it's one of those where they would recommend that everyone get, at this point, a booster, typically in the seasonal patterns that we do for influenza, but the challenge with COVID is that we're still kind of waiting for it to truly become seasonal. It's still, we don't get the surges like we once had, but we still have surges at different time of the year. And the vaccine, like any vaccine for an upper respiratory infection, is going to wane about 4 to 6 months after you administer it, which is, yeah, and that's the same thing that happens with the flu vaccine, which is why we administer it in the fall, just before flu season, and then it ideally protects you during flu season, because flu has a very typical, predictable seasonality to it. And typically then that season ends in March, April, and that's about the time that then your vaccine is starting to wear off, which is why October is the best time to get an influenza vaccine. And so at this point, the people that I'm advising the strongest to get COVID vaccines and that I'm talking to are people who are immunocompromised, their immune system doesn't work well, people with respiratory conditions or heart conditions that will get extremely sick if they do get COVID or could end up hospitalized, and especially our older adults.
What about people that are around immunocompromised individuals? Is there a benefit to having the vaccine if you're around somebody that may be compromised?
So likely there is. I think we don't have really, as far as I know, to be clear, very, very strong data about this sort of cocooning effect that we had hoped to enact when people receive the vaccine. Because it's like it can decrease your risk of getting sick, but it's not going to stop it. And that's how almost all vaccines work, is they decrease your risk of getting sick substantially, but not necessarily stop it. And then it keeps it from getting serious. And the same thing is how an influenza vaccine works. I can't necessarily stop you from getting influenza, but I can keep you from getting seriously ill, ending up in the ICU or ending up hospitalized or dying from it. And that's the goal of a COVID vaccine, is I want to keep you from getting seriously ill and I want to keep you from dying from COVID-19. We do have reasonably good treatments, but by the time you're presenting now for treatment, whether you're getting Paxlovid, which is the oral medication, or you're in the hospital and getting one of the IV medications, frequently you're already quite sick and now you're running the risk of getting long COVID. Which are sometimes the dysautonomic effects that sometimes people will experience, or something called chronic encephalomyelitis. I'm sorry, chronic fatigue syndrome is the easier way to say it. That the first thing I said sounds really scary, but it's not as scary as it sounds, but it is very debilitating. And it's a recognized syndrome that they had thought was caused by viruses, but I think has gotten a lot more credence since COVID-19, because we see a lot more people with chronic fatigue syndrome after having COVID. And it's just this extremely debilitating, energy completely zapped, just sometimes people will have autonomic symptoms, like their heart will just begin to race, or palpitations, and these things just never quite balance out for some of these folks who have long COVID. And we don't fully understand, we don't have great treatments for chronic fatigue syndrome. It's kind of graded return to activity, but some of these folks have lost hobbies like running and things like that because their chronic fatigue syndrome is so severe. So if we can get ahead of something like that by helping to control the infection before you get more sick or get more viremic, because you can get viremic with COVID-19, but not necessarily in the way that's going to result in lifelong immunity, again, because of the way the virus entered the system and the way that the virus drifts from over time. The more of that antigen that's in the system, the more sick that you're going to get, and the more likely then you're going to have for the higher probability that you could develop something like chronic fatigue syndrome or long COVID.
So I'm curious too. Like one of the things that I hear from the anti-vax group is the things that are inside of one of the shots, like aluminum, mercury. I did a little bit of research on it. It seems like the amounts that are in there are like negligible. In fact, in a lot of cases, if you're just breathing the air around you, you're likely to take in more, mercury and aluminum than you would actually in the vaccine itself.
Yeah.
But I guess, is that something like, I mean, if you're putting a heavy metal into a body, I feel like that would have some neurological impact, but because it's so low, it's just like, meh.
So dose makes the poison. right, is the way that you can think about it.
Yeah, because water can be poison if you drink too much of it.
Right, the dose makes the poison, and the metals that are there occasionally, they actually removed some of them anyways, just out of sort of an abundance of caution. Fine, this wasn't really that important to the vaccine anyways, and if you're going to worry about it, let's just take it out. Now, the government does stop giving vaccines when they're not necessary anymore. So, for instance, we don't give smallpox vaccines on large scale. That was something that we did in like our parents both got smallpox vaccine. If you ask our dad, he'll show you the scar from where he got his smallpox vaccine. We no longer give smallpox vaccines on large scales because it's been eradicated, and it only sits inside a few locked away sort of vaults around the world. And so once it's eliminated, we stop giving the vaccine.
I always wondered about that. Okay, that makes sense.
Yeah. Now, on the other side, if a vaccine is showing that it's having adverse effects, they will remove it from the market. So there were live polio vaccines that were given. Actually, you and I would have been sort of in the age range that we would have received them, that there were some children, because it was a live virus, it wasn't attenuated quite right, and some children did get polio from that vaccine. That vaccine was taken off the market, and now we give an inactivated polio vaccine. We do not give live polio vaccines anymore, at least in the States.
Are there any, I mean, so we talked about some of the adverse reactions. Really, it was just that rash thing that we talked about.
Yeah.
Is there any real documented danger? Like, you see, you go on Facebook, you scroll through there, you're gonna see somebody, oh, if you get the jab, then you're gonna be dead in a year.
Yeah.
Like, is there any credence to this? Like, where is it coming from?
So what I would say is that all vaccines, just like all medications, come with risks. And so it's important to acknowledge that nothing that you put in your body is 100% safe all the time. And this is why we do big studies to administer the vaccine or a placebo or something, and to look for these things to happen. And that's why we look. And especially, again, with vaccines, if something bad's going to happen, it's going to happen within 2 months of administration of the vaccine. Within 2 months, which is why you don't necessarily need to watch for years. But knowing that mRNA technology has been around for 10, now 15 years, we know that there are people walking around who have had mRNA in their system for over 10 to 15 years, and we have not seen any adverse effects that seem to indicate that anything is happening. Now, there is a risk of myocarditis, which is an inflammation of the heart. This is typically in young men or teenage boys. It's self-limited. It has never, as far as I understand, actually resulted in anyone dying from it. And the risk of the myocarditis is much higher from actually getting COVID than it is from getting the vaccine.
Yes, it is.
And so this is why, for most people, I'm deliberately exposing myself to something that could result in myocarditis, although the risk is very low. The risk that I'm going to get exposed to COVID is equally, if not higher, right? I'm probably going to run into COVID at some point, and the risk during that infection is substantially higher of getting myocarditis than it is from getting the vaccine. But on the other side of that, the risk is still relatively small, even among people who do end up getting COVID. But if you're going to compare these two risks, it is substantially smaller from getting the vaccine. So, like, we have to be, as clinicians, as scientists, the key to hopefully earning the public's trust is through transparency. I'm never going to lie to you, and I'm never going to tell you I know something that I don't know. I'm always going to be as clear as possible, even when I'm talking to someone about starting a new medication for their blood pressure, for diabetes. What we need to do is talk about the risks, benefits, and alternatives to whatever this is. So let's take a moment and think about these things. For most of the time, the benefits outweigh the risks, and we just have to help that individual make a decision. At the end of the day, my job is to give you information. It is to help you understand that information, to give you the information that you need to make a decision that fits with your belief system, who you are as a human, and what your goals are for your health. I can't make you do things. I can offer you my ideas. I can't tell you what you should do. But I can give you every opportunity to get what I am trying to convey is the most accurate possible information that's transparent. I'm not going to make grandiose statements. I'm going to do my best to just I'm going to shoot straight with you. I'm going to tell you this is what my understanding of the data is, or are rather.
I feel like when you look at a lot of the things out there, like all you're seeing is grandiose statements. So I feel like you're really fighting this uphill battle against all these. Really, I see a lot of it just perpetuated on a few particular news networks, and I don't know. I just don't get it. It feels like when I look at the data and I look at the benefits versus the drawbacks, it seems really, really clear what to do. But then you add in this little bit of gray area, and suddenly the water's muddied, but for no reason.
And that's where it's challenging because, people will sometimes mistake transparency and nuance for lack of expertise or not knowing what you're talking about, right? And so, but when someone comes in with a lot of bravado and a whole lot of certainty and big grandiose statements, it sounds like they know what they're talking about just because they're acting like they know what they're talking about. But the moment that somebody comes to you and is I lay it out on the table, like, I'm going to show you all my cards. I have nothing to hide here. I'm not going to speak in extremes because that would be not truthful. If I talk to you in complete, black and white all the time, then generally I don't know enough to know what I don't know. And that's what that's the Dunning-Kruger effect, right? So there's the moment that you learn about some new field or task, you immediately end up on the top of what we call Mount Stupid, which is where you know a little bit, but you don't know what you don't know, and you think you know everything. And then you read more and you learn more and you fall down into the trench of despair, which is where you realize what you don't know and you become like overwhelmed or distraught, by this, oh my gosh, I don't understand this and I don't know this and there's all this other stuff and this is 100% more complicated than I thought it was and there's all these other things going on. And then hopefully you slowly ascend up the slope of enlightenment, which is where you have a mastery of the known information, and it's not uncomfortable to say, this is what we don't know. And if you're a researcher like me, that's where I get excited because I know the things that are well demonstrated in literature, say around neighborhoods and health and things like that. But there's these places where we don't have the connection, where we don't fully understand, where there's more to learn and where there's more things to get into. And for all of that, that's where I'm really excited.
So we're getting towards the end of this interview. So of course, I'm going to use it to be a little experiment. One of my journalism professors told me that the best time to ask the most controversial questions is at the end of the interview. So here's my question. Do you believe in the lab leak hypothesis or no?
I'm going to say with nuance that we don't know. I'm going to say that that it's still on the table is what I'm going to tell you, is that it's on the table, that could be part of the origin of the virus.
Can I ask who cares? Or why does it matter?
Because I will say this though, if it is a man-made process, we need to, the COVID-19 was made in a lab, we need to make sure this never ever happens again. I speak as someone who's had both relatives on my mother's and my father's side died of COVID.
And accountability is important, right? And transparency again, right? Were there protocols that were broken? If that is the origin of the virus, were there protocols? Were there irresponsible use of experimentation of viruses? We don't know any of that, and it's going to be darn hard to get in there and figure it out.
But for now, I think this is just my personal opinion. We should end gain-of-function research because it was something that was banned by the Obama administration. Basically, it's a process where you create viruses that are deadly. I'm using a very bastardized version of it, but you make viruses that are stronger than those found in nature for research purposes. Again, I apologize if I'm butchering it, but this was banned by the Obama administration, but the ban was lifted by the Trump administration. This needs to be banned. If there's something was banned for a reason, there might be a reason for it.
Well, I think back to like Lyme disease. I know there was some some DNA that was involved there, and they were actually able to track the mutations within Lyme disease back to origin sources along the East Coast, and supposedly it came from a government facility on an island where exactly.
Never heard any of that. So
you didn't hear it? The Jesse Ventura did a whole episode on his thing. I mean, this was years ago. It's been out for a long time. But and this is actually one of the conspiracies that Dad worked on.
Let's not get too into that.
Exactly. Well, it's interesting. It's interesting because it was. I mean, I found it interesting. According to him, they were able to use the genetics of the virus and able to detail with great accuracy where it actually came from.
So it's not a virus, P.S.
Oh, sorry,
Borrelia burgdorferi is
I'm not a
bacteria.
doctor. Get out of here.
Spirochete.
Spirochete, yeah, that's the word. Spirochete.
So it's a type of bacteria.
But yeah.
I had a question when you started talking about we've eradicated polio, so we've taken that vaccine off the market, and
we have not eradicated polio. That's not true. Smallpox.
It's gone past
smallpox is what we eradicated. Correct.
So
we haven't eradicated polio. Sorry.
No.
Anyway, smallpox.
It's other parts of the world. It was eradicated from the United States. There were only cases coming from other places.
I'm going to be blunt about something. Polio is much more frightening than COVID.
But I guess we also talked that we're part of this generation where we just missed that chickenpox vaccine, but our kids got it. Do you think that's something that's going to get eradicated in our lifetime, or how long does something like that take?
So it sort of depends, right? So smallpox vaccines, if we kind of look at it as an example, the first time that we sort of understood even the remote idea of a smallpox vaccine was in the, if I remember correctly, 18th century. And actually, smallpox vaccines are about as American as they come. George Washington vaccinated his own troops against smallpox, and it was part of his victory. Yes, it was part of his victory. Now, as time has gone on, they were able to, hone that technology into smallpox vaccines that work well, but are still a bit more dangerous than a lot of the other vaccines that are on the market, which is why once it was eradicated from the world, and if you imagine, if that was when they were first starting to give vaccines in the late 18th century, and again, I don't want to be quoted on those exact dates. I could have my history here wrong. It took through the 19th century, the 1800s, up until well into the 20th century before it was declared eradicated from the world. And there now, again, it's only held in very particular facilities that can contain it. Now, the reason we still do vaccinate like military personnel is because of the potential for biologic warfare. And so a lot of military recruits will still get a smallpox vaccine.
1796, and it was published in 1798.
Okay, so I'm not doing too bad. Not doing too bad. Okay.
I didn't know it went back that far, like legitimately. Yeah. I thought this technology started in like the 50s. Like I had no idea it went back to
Yeah, and that was because they noticed that the milkmaids who had cowpox were immune then to smallpox. And so that's when they started recognizing that, oh, wait, this virus is similar. Maybe a small exposure might be able to prevent larger scale disease. And that's when they began to.
So I just to let you guys know, we've run out of time. So I think we can end this show on a high note. So if you want one final question.
Yes.
Oh man, I've got so many questions. Well, let me see what you guys got.
I'll leave it to you, boys. Do I want to get real controversial with it?
I thought we were ending on a high note.
Well, he said to wait till the end of the interview to ask controversial questions.
Of course, my journalism professor said this question when he was interviewing R. Kelly's ex-wife.
Okay.
I mean, that would be a good time to do that gotcha journalism. I don't. I guess I want to know from you, Sarah. Like, what if there's one piece of information that you would want the general public to know that would maybe change their minds or convince them of acting in a more safe way? What do you think that would be?
Well, I guess we need to be more clear about like what sort of safety are we talking about, right? Because there's a lot of different types of safety. Wear a helmet when you ride a motorcycle or your bike. Wear your
I made it broad
seatbelt.
so you can
Wash your
infer.
hands. Probably the biggest take home I would ask, and maybe it's less about safety and more about something that Melissa kind of asked about is how do you talk to your doctor, and what kind of things you should look for a physician that's going to take care of you, take care of your family. And the thing that I think is most important is that they listen to you, and that you are able to tell them what they need to tell you, and that they're maybe not going to order the obscure test that you ask for, but they should tell you why, and they should explain to you in a way that makes sense to you. And if you are seeing a clinician that kind of gives you weird bravado sort of answers, that dismisses your complaints, that kind of just that's not giving you what you need from them, then you need to find somebody else, which can be really, really hard, really, really hard. But hopefully, that's my hope for anybody, is to have a primary care clinician that they feel comfortable with, that is accepting of them for who they are, that they do not feel judged by, and that they feel like they can air whatever concern, no matter how silly they might think it is, and that they will be able to listen to them, that they will educate them on whatever it is, and that they will chase down the appropriate things that could be going on, so that you don't have an experience like I had, where you have a clinician that doesn't listen to you, that fires you, and then I actually am considering writing him a strongly worded letter all these years later, because I like to think he would want to know that he missed a brain tumor diagnosis, and that I'm not doing too bad for somebody who's a little brain damaged.
Okay.
I don't know. It's also like a big middle figure. I just have a quick follow-up question before we end things on Shimon. If you're in one of those situations, just say if I'm moving to a new city, what do you recommend for somebody to find a physician that you feel might fit their needs, or is it just kind of a roll of the dice?
Ooh, that's really hard. It is kind of a roll of the dice, unfortunately, because everybody needs something a little different from the clinician that takes care of them. Yeah. And if you look at reviews online, I got brave enough to actually look at mine today. I think I have like 2 out of 5 stars on one of my reviews, which in the long run.
Didn't fill that pain prescription.
You know what? I don't know what was going through that patient's mind, and I can't speak to that. But what I can say is that I'm here for the patients that I take care of. I have a panel of patients, many of them I've been taking care of for 9 years, that come back and see me, that I like to think I do a good job taking care of. And so sometimes word of mouth, it just sort of depends on what kind of keywords are you hearing from that person that you're talking to that's the reason that they like their doctor. Is it because their doctor listens to them? Is it because their doctor's on time? So I tend to run behind, because when I'm taking care of my patients, when I'm in the room, you have me, and I'm going to do everything I can for you in that time, especially with an underserved population. I need to address as much as I can. So if you want me to run, if you want a doc that runs on time, sorry.
Thank you for everything, Dr. G. This has been Peoria Life, and thank you to our audience for watching. See you next time.